Hello everyone. So today we'll discuss the latest INISS questions of April 2026. So let's start with the first question. Patient with bladder tumor underwent TURBT outside. Final histopathology turned out to be high-grade T1 urothelial cancer. What is the next step in management? And the options are A. Restaging TURBT, B. Intravesical BCG, C. Intravesical mitomycin C, and D. Intravesical gemcitabine with docetaxel. Right? Now the answer to this question is restaging TURBT. How? Let's understand it. Staging of bladder tumors is very important. Why? Because bladder cancers are divided into muscle invasive bladder cancer and non-muscle invasive bladder cancer. Now the treatment of muscle invasive bladder cancer is neoadjuvant chemotherapy followed by radical cystectomy. Whereas the treatment of non-muscle invasive bladder cancer is TURBT plus minus intravesical chemotherapy or immunotherapy. Right? Therefore, staging of bladder cancers is very important because the treatment of muscle invasive bladder cancers differs drastically as compared to non-muscle invasive bladder cancers. Now, in cases of high-grade TA tumors, when you perform a TURBT, the risk of upstaging of the bladder cancer on a restage TURBT is about 15%. Whereas for high-grade T1 tumor, the risk of upstaging ranges from 30 to 60%. Therefore, if I perform a restage TURBT in such a case, there is a 30 to 60% chance that it may be actually a muscle invasive bladder cancer rather than it being a non-muscle invasive bladder cancer. Right? Therefore, in high-grade T1 tumor, if I perform a restage TURBT, there is a 30 to 60% chance that the tumor may turn out to be actually a muscle invasive bladder cancer rather than being a non-muscle invasive bladder cancer. Therefore, in such cases, you should first confirm the stage with the restage TURBT before deciding on further management. Now let's look at the question again. He underwent TURBT outside. Right? So you have not performed the primary TURBT and the final histopathology turned out to be high grade T1. Therefore, there is a 30 to 60% chance that the tumor may actually be a muscle invasive bladder cancer. So, you first confirm the stage with the restage TURBT before deciding on the further management of this patient. Right? Let's move on to the next question. What is the tract size in ultra mini PCNL? And the options are A. 20 to 24 French, B. 14 to 20 French, C. 9 to 11 French, and D. 11 to 13 French. And the answer to this question is 11 to 13 French. Let's look at the classification of PCNL according to the tract size. So based on the tract size, we have various types of PCNL. In standard PCNL, you have a tract size from 24 to 32 French. Standard PCNL was first described by Fernstorm and Johansson. In mini PCNL, the tract size ranges from 14 to 22 French. And mini PCNL was first described by O'Donegal. Although some people give the credit to Lahame for first describing mini PCNL. Ultra mini PCNL, the tract size is 11 to 13 French and it was first described by Janak Desai. And micro PCNL, the tract size is 4.85 French. The needle for micro PCNL was developed by Shaft and Bader, and Mahesh Desai was the one who first did the fragmentation using this needle. Right? So this is the classification of PCNL according to the tract size. Next question. What is the isotope number of lutetium? A 177, B 167, C 68, and D 67. And the answer to this question is 177. Now this lutetium is a very important isotope. Why? Because it is a classical example of thernostics. What is thernostics? It is basically a term derived from the combination of therapeutics plus diagnostics. Right? So the same agent can be used as a diagnostic agent used to visualize the disease, as well as the same agent can be used as a therapeutic agent used to treat the disease. Right? So lutetium is a classical example of thernostics, and the trial that is related to lutetium is the vision trial. Now this is a question that may be asked in your future exam. Vision trial is a randomized open label phase 3 trial which incorporated metastatic castration resistant prostate cancer patients. Right? These patients were already exposed to one androgen receptor targeting agent as well as one or two taxane regimen and were found to be positive on gallium 68 PSMA PET-CT. Now, when these patients were given lutetium 177 PSMA therapy for 4 to 6 cycles, they were found to have increased overall survival and increased radiographic progression-free survival. This is one of the latest advancements in prostate cancer and therefore has been asked in your exam. Now, the next question. A patient presents to you with grade 4 renal injury with urine leak. The patient is hemodynamically stable. 3 days later, however, the patient develops a collection, query a urinoma, along with fever on the same day. Now, what is the next step in management? And the options are A. DJ stent, B. Emergency nephrectomy, C. Wait and watch, and D. A nephrostomy. Now, even if you do not know what's a grade 4 renal injury, you will be able to rule out at least two options. Right? So, due to some sort of a renal injury, the patient has developed a urine leak. Now, a patient has developed a collection due to the urine leak. So, a collection may be asymptomatic or a collection may be symptomatic. This collection that has formed in the patient is symptomatic as the patient has now started having fever. Therefore, for such a symptomatic collection, you would not wait and watch. So, this option is ruled out. Second thing, the patient is hemodynamically stable. He is not losing blood actively. The patient is hemodynamically stable. So, why would you perform an emergency nephrectomy in such a patient? This option is also ruled out. Now, we are left with two options A DJ stent, and D, a nephrostomy. So, how do you choose between these two answers? That is wherein you should know what is a grade 4 renal injury. Now, let's look at the latest renal injury scale of 2018. In grade 4 laceration, we have two types of injury. Number one is a parenchymal laceration extending into the collecting system with urinary extravasation. And the second is a renal pelvis laceration or a complete UPJ disruption. Now, the treatment for the first type of injury is a DJ stenting, and if DJ stent cannot be placed, then a percutaneous nephrostomy. Right? So, majority of the cases of parenchymal laceration extending into the collecting system can be dealt with a DJ stent itself. Whereas in the second type of injury, if there is a complete UPJ disruption, let's say this is your kidney, this is your renal pelvis, and this is your ureter. Now, if there is a complete UPJ disruption, how are you going to place a DJ stent in such a case? Therefore, the treatment of this type of injury is placement of a PCA. Now, in the question, if you are given the exact injury by giving an image, then you can simply answer whether you can place a DJ stent or not, and accordingly you will choose the option DJ stenting or a nephrostomy. However, if you are not given the image and you are simply given a grade 4 renal injury, then I would choose the answer PCN over a digestate. Reason: a percutaneous nephrostomy can be used to treat the condition number 1 as well as condition number 2, whereas DJ stenting can be used to solve a parenchymal laceration extending into the collecting system but not a complete UPJ disruption. Since I am not given the exact injury, I'll choose a I'll choose a treatment which can treat both the condition, or I'll presume the worst case scenario and choose a PCN over a DJ stent. So in this question, since our two options were already ruled out, now you are given a grade 4 renal injury with urine leak and you do not know, no image has been given in this question. So instead of choosing a DJ stunt as the answer, my answer to this question will be a nephrostomy. Why? Because it can treat a complete UPJ disruption also, as well as a renal parenchymal laceration extending into the collecting system. That is why this is a better answer as compared to a TG stunt. Right? Now, a young female with solitary functioning kidney, previously diagnosed case of tuberculosis, has taken ATT for 6 months. She presents with complaints of increased frequency. However, there is no lab evidence of active TB at present. Urine routine and cultures are normal. The bladder capacity is around 20 to 40 ml. Serum creatinine is 1.6. She voids every 30 minutes. What is the appropriate management? And the options are A. Continue ATT, B. Change ATT regimen, C. Augmentation cystoplasty, and D. Medical management. Right? Now, let's look at this question once again. Young female with solitary functioning kidney. Now, she was diagnosed to have tuberculosis and has already taken ATT for 6 months. Now, she presents with complaints of increased frequency. Now, till now, the scenario says the patient has increased frequency despite ATT. Now, when the patient takes ATT, there is usually improvement in systemic symptoms. Example, fever, loss of appetite. Whereas post ATT, there is worsening in urinary complaints. Example, frequency, urgency, nocturia. Why? Because when you give ATT, the organisms die. And due to the inflammation, the bladder gets fibrosed. When the bladder gets fibrosed, its capacity decreases and there is a worsening of urinary complaints. However, increased frequency may be due to three things. Number one is either adequate ATT and as a normal response of fibrosis. Second is inadequate treatment, either due to resistant organisms or due to decreased duration of treatment. So increased frequency may be a normal phenomena as a result of adequate ATT being given and the bladder getting fibrosed, or it may also be due to inadequate treatment. Either the organisms are resistant or you have not given an appropriate duration of treatment. Now, there is no lab evidence of active TB at present. That means they have already ruled out there is no inadequate treatment. It is not a resistant organism and there is no decreased duration of treatment. The TB has been treated adequately and there is no evidence of active TB at present. Therefore, you should not continue ATT at all, number one, and you should not change the ATT regimen in view of resistant organisms, since all organisms have already died and there is no active TB at present. Right? So we are left with two options, augmentation cystoplasty and medical management. Now, urine routine and cultures are normal. That means increased frequency is not due to a superimposed UTI. The bladder capacity has reduced to 20 to 40 ml. That means the bladder has become a thimble bladder and the creatinine is 1.6. She has debilitating symptoms. She is voiding every 30 minutes. That means within 24 hours, she goes to the bathroom at least 24 times. Right? Now, the patient has number one, debilitating symptoms. The patient has a thimble bladder as well as a solitary kidney. This thimble bladder may also put pressure on the solitary kidney as well due to its reduced capacity. Therefore, in such a clinical scenario, you would perform augmentation cystoplasty for the patient. Right? So, what you have been shown is this type of a clinical scenario. This is the solitary functioning kidney, and this is the thimble bladder. Can you see it is so much reduced in capacity? Thimble is basically a cap worn on the finger during sewing in order to prevent needle stick injuries. Right? So, the bladder has reduced in capacity, and now we have only one kidney left. Additionally, the patient has debilitating symptoms. So in such case scenario, you would prefer to choose surgical management with augmentation cystoplasty rather than medically managing her symptoms. Right? So coming on to the next question. Patient with 35-gram prostate presented with urinary retention. Now, urinary retention was relieved by placing a periurethral catheter. What is the next step in management? And the options are A. TURP, B. Silodosin with catheter removal after 3 days. C. Tamsulosin with catheter removal after 1 week. And D. Tamsulosin with dutasteride with catheter removal after 1 week. Right? So, how do you manage acute urinary retention in a patient? Now, the trial without catheterization, TWOC, trial without catheterization. This is the preferred management after initial decompression by bladder catheterization. Right? So you do not proceed directly to surgery, you first attempt a trial without catheterization. And for trial without catheterization, you should always give alpha blockers to the patient. These are recommended to increase the odds of successful trial without catheterization. Right? 5 alpha reductase inhibitors like dutasteride and finasteride, they decrease the risk of acute urinary retention in patients with moderate to severe LUTs. So in order to improve the success, you give it with alpha blockers, and these 5 alpha reductase inhibitors decrease the subsequent risk of acute urinary retention in such patients. So let's come back to our question again. Now the patient had an episode of acute urinary retention which was relieved with catheterization. Therefore, directly you do not proceed with TURP in such a patient. Now you have to choose between these three options. So all these three options say a trial without catheterization. Right? Now, alpha blockers all have equal efficacy whether be it silodosin or tamsulosin. So these are not the differentiating features in the question. The patient has a 35-gram prostate. Dutasteride is usually indicated in prostates with more than 40 gram. Right? Therefore, this is not the answer to this question. Right? They are just asking what is the next step in management. Our next step in management is to attempt a trial without catheterization, and you need to give just alpha blockers to this patient since the patient has a small prostate, less than 40 cc. Right? Now, if the answer is between B and C, how do we choose? So, majority of the trials have attempted trial without catheterization after 3 to 8 days with a median of 5 days. Right? Now, there is no specific guidelines giving the exact day on which you should attempt trial without catheterization. So, choosing between this and this is relatively difficult. I would take the answer as this rather than B. Reason is that in clinical practice also, we usually attempt trial without catheterization after 1 week rather than such a short duration of 3 days. Because it takes about 48 to 72 hours for the bladder neck edema to subside, right? So, although people have attempted at 3 days also, I would prefer to choose 1 week as the answer to this question rather than 3 days, because this is much more commonly followed in clinical practice and there is no specific cutoff for it. Right? Now, let's move on to the next question. A female patient incidentally detected with an adrenal gland mass. The size was given query 3 centimeter. Which of the following warrants further workup in this patient? And the options are A. Hypokalemia, B. Hypertension, C. Hypokalemia and hypertension, and D. All adenomas should be screened. And the answer to this question is all adenomas should be screened. Why? Now, this is a very hot topic among adrenal disorders, adrenal incidentalloma. Nearly every year, 1 to 2 questions are asked from adrenal gland disorders, and it is usually from an adrenal incidentalloma itself. So, first of all, what's an adrenal incidentalloma? They are unsuspected adrenal masses more than 1 centimeter in diameter, which are identified on cross sectional imaging performed for seemingly unrelated causes. Right? So, female patient incidentally detected with an adrenal gland mass of size 3 centimeter. Therefore, it's an adrenal incidentalloma. Now, an adrenal incidentalloma may be functional, it may be malignant, and it may be benign and non-functional. Right? No treatment should be done for such lesions, whereas functional and malignant lesions are potentially surgical lesions that should be removed. And such lesions constitute about 20% of the patients. Right? Therefore, you should screen all adenomas to identify whether they are malignant lesions or they are functional lesions, because all such functional and malignant lesions should be excised. So let's take an example. Suppose I have an adenoma of 2 centimeter and the patient is completely asymptomatic. But I screen it and it turns out that this adenoma is synthesizing excess cortisol. Right? Therefore, currently the patient has no symptoms, but when the size of this mass increases or it starts synthesizing more and more cortisol, it can lead to Cushing syndrome in the future. Therefore, the patient currently has subclinical Cushing syndrome. However, in order to prevent it from developing clinical Cushing syndrome, you need to surgically excise it. So, even if the patient is asymptomatic, you should detect whether the lesion is functional or not, or maybe harboring a malignancy. So, by screening all adenomas, you can detect early functional lesions and prevent the manifestations of and prevent florid manifestation, as well as you can detect malignancy at an early stage and can cure the disease. Right? Therefore, all adrenal incidentalomas should be screened to identify potentially surgical lesions. Now, coming on to the next question. Elderly male underwent robotic prostatectomy. What is the single most important factor for early return of continence when hood technique is used? And the options are A. Base to apex dissection posteriorly, B. Preservation of anterior periurethral hood structures, C. Preservation of bladder neck, and D. Reduced injury to autonomic nerve plexus. Now, one option is totally ruled out. Base to apex dissection posteriorly does not help in early return of continence. Rest three options can help in early return of continence. However, they have specifically asked what does the hood technique lead to? What is the most important factor according to the hood technique? Now, I don't think so. Majority or in fact any of you would know the answer to this question. But in the exam, if you have the willpower to solve the question, you will be able to solve this question. What is most important according to the hood technique? It is named hood technique because it wants to preserve the hood structures, right? If you apply simple logic itself, yes, this is the answer to this question, preservation of the anterior periurethral hood structure. That is why, in fact, it has been named as the hood technique, right? So the answer to this question is preservation of anterior periurethral hood structures. Now let's look at what the hood technique is. Now it's a modification to our anterior approach, wherein you preserve the musculofacial structures anterior to the prostate. And these preserved tissue have the appearance of a hood comprising of the detrusor apron, the arcus tendineus, puboprostatic ligament, anterior vessels, and some fibers of the detrusor muscle. Right? This hood surrounds and safeguards the membranous urethra, external sphincter, and supportive structures, and leads to early return of continence after surgery without compromising any surgical margin. So how does the hood looks like? So this is how the hood looks like, right? So this is the detrusor apron. These are the puboprostatic ligaments. This is the arcus tendineus. So after dissection, it looks like a hood. You preserve this hood in order to help in early return of continence. Again, we have some pictures. Can you see the exact hood? Right? Again, one more picture. This is the anterior reconstruction being performed by suturing the bladder to the arcus tendineus. So this is the hood that was left, and we are here now performing the anterior reconstruction. Right? Now, irrigation fluid used in bipolar TURP. And the options are A. Normal saline, B. Distilled water, C. 1.2% glycine, and D. 1.5% glycine. And the answer to this question is A. Normal saline. Why? Now, if you look at bipolar TURP, let's say this is your loop, right? From this, current goes from this active electrode. Current goes to a conducting irrigant, right? Conducting irrigant like normal saline. This conducting irrigant in turn forms plasma, which is conducted to the tissues and is used to cut the tissues, right? And from there it returns to the inactive electrode, which is located on the same loop, right? So this is how the current gets conducted from the active electrode to the inactive electrode in bipolar TURP. You need a conducting irrigant, whereas in monopolar TURP, you need a non-conducting irrigant. The reason is that if you use a conducting irrigant in monopolar TURP, it is going to dissipate the current. Whereas in bipolar TURP, this conducting irrigant forms the plasma. The sodium ions get excited and they form the plasma, and that is responsible for the orangish glow of the electrode, right? Therefore, you need normal saline for this patient. In the last exam, they had twisted the language, the answer remained the same. Which irrigation fluid is not used in monopolar TURP? And the answer again remains the same, that is normal saline, right? This is the only conducting irrigant, rest three are non-conducting irrigants. Now, let's come on to the next question. Which of the following is not a minimally invasive surgical technique in BPH? And the options are A. Resume, B. Urolift, C. iTind, and D. HIFU. And the answer to this question is HIFU. Now, minimally invasive surgical techniques in BPH have been asked repeatedly in your exam. Multiple times the same question itself. So you need to be thorough with all these techniques. And the techniques are number 1, Urolift, number 2, Resume, number 3, Aquablation, number 4, iTind, and number 5 is prostatic artery embolization, right? So let's look at each one of them. This is what is the Urolift procedure, also known as prosthetic urethral lift, PUL. Right? So what you do in this procedure is that with the help of a cystoscopically guided handheld device, you place transprostatic implants into the prostate. Right? So these implants are placed into the prostate, and these in turn help to compress the prostatic parenchyma. This in turn opens the prostatic urethra, leading to a widened channel. Right? This is what is known as a Urolift procedure. This image is of resume. Resume is used for convective, radiofrequency, water vapor, thermal therapy. Right? So what it shows is that this is what is a radiofrequency generator. With the help of this radiofrequency generator, you generate water vapor. Right? This water vapor is injected with the help of this handheld device into the prostatic parenchyma. Now, when this water vapor is delivered into the prostatic parenchyma at a slightly higher pressure than the atmospheric pressure, it gets condensed into water when it touches the prostatic tissue. Now, this water vapor is usually delivered at 103 degrees Celsius for 9 seconds. When it gets condensed into water after touching the prostatic tissue, it releases a large amount of heat, leading to necrosis of the prostate tissue. Right? The method with which this heat is delivered is convection, not conduction, unlike in tuna. Right? And when it leads to coagulation of the prostate tissue, it leads to widening of the prostate channel. So this is what is resume therapy. Third, we have aqua ablation. Now, as the name suggests, it is the ablation of prostatic tissue using high velocity water saline jets. Right? So, we are basically ablating the prostate tissue with the help of high velocity water saline jets. The machine for this aqua ablation has been developed by Procept Biorobotics. So, this is what the machine looks like. It consists of a console which is used to deliver the high velocity water saline jets. It consists of a transrectal probe. It is inserted transrectally and is used to guide the prostate ablation. And third, we have the handpiece. Now, this handpiece is robotically controlled and is inserted into the urethra. And with the help of this console, this handpiece delivers the high velocity water saline jets, which is used to ablate the prostatic tissue. Right? This is what is known as aqua ablation. Last, we have iTind. TIND stands for temporary implantable nitinol device. The entire full form gives you the exact mechanism. So this is basically what an iTind looks like. This is a nitinol device measuring about 5 centimeter in length and is about 33 mm in diameter. Right? It consists of an anchoring leaflet which is placed at 6 o'clock position and 3 wire struts which are placed at 12 o'clock, 5 o'clock and 7 o'clock position. Right? As the name suggests, it is implanted into the urethra temporarily. So with the help of a cystoscopically guided handheld device, it comes into a preloaded configuration and is implanted into the urethra covering the entire length of the prostatic urethra. Right? With the anchoring leaflet positioned at 6 o'clock and the remaining 3 wires at 12, 5 and 7 o'clock position. Now when it is deployed, it opens up, leading to opening of the prostatic urethra. and it is placed temporarily, that is for a duration of 5 days. So within 5 days, these three wires cause pressure necrosis of the prostate, leading to reconfiguration of the prostatic channel and widening up the lumen. After 5 days, this item is removed cystoscopically itself. So it is a temporarily implantable nitinol device, right? With the help of this device, due to pressure necrosis, you can reconfigure the urethra and thereby lead to widened channel, allowing flow of urine. So the next question was identify the image. Again, same exam, two questions from the same topic. And this was the image that was given. And the answer to this question is therefore aquablation. Moving on to the next question. A patient with priapism presented to casualty with painful erections. Now it's already been treated with ephedrine injection, but it does not get resolved. Now what is the next line of management? And the options are A. Percutaneous distal shunt, B. Resuscitate with high flow oxygen, C. A proximal shunt, and D. Open distal shunt. And the answer to this question is percutaneous distal shunt. Why? Patient has priapism presenting with painful erections. This implies that the patient is a case of ischemic priapism. So once you have diagnosed ischemic priapism, the next step in management is therapeutic aspiration of erection along with intracavernous ephedrine injection. Now they have said that this has already failed. So the next step in management comes out to be distal percutaneous shunting. Right? So this is the answer to our question. If a distal percutaneous shunt fails, then only we'll resort to open distal shunting. And if the open distal shunting fails, then you can either counsel the patient for a penile implant or you can perform a proximal shunting for the patient. Right? So the answer here is percutaneous distal shunt. If it fails, then you will perform an open distal shunt. And if it fails, then you will perform a proximal shunt for the patient. Next question. A CECT abdomen image was given and the diagnosis was asked. We do not have the image, we just have the answer. The answer was emphysematous pyelonephritis. Now, this question has been repeatedly asked in your exam. Therefore, emphysematous pyelonephritis is a very, very important image. This is how emphysematous pyelonephritis looks like. You can see air pockets within the collecting system as well as within the renal parenchyma, right? So the image here shows bilateral emphysematous pyelonephritis. Now there are two classification systems. One is the Van classification, which was used previously, and now we have the latest Huang and Sang classification, which is used for emphysematous pyelonephritis. According to it, we have four classes of emphysematous pyelonephritis. Class 1 is when the gas is confined to the collecting system. Class 2 is when the gas is confined to the renal parenchyma alone. Class 3A is perinephric extension of the gas or abscess. 3B is extension of gas beyond the Gerota's fascia. And class 4 is bilateral emphysematous pyelonephritis or emphysematous pyelonephritis in a solitary kidney. So you may in fact even be asked the class of emphysematous pyelonephritis in the exam. And this classification is important because of management point of view. Now in class 1, all you need to do is treat the patient with IV antibiotics. Whereas in class 2, you need to give the patient IV antibiotics along with drainage of the collecting system with the help of a DJ stenting or a PCN along with a percutaneous drain placement. Right? In class 3, if the patient has some severe signs, example thrombocytopenia, mental status changes, acute renal failure or shock, then in such cases you need to perform immediate nephrectomy, right? And in class 4, since the patient has a solitary kidney only, again the treatment is IV antibiotics along with a degestant or a PCN placement along with a PCD placement. Let's come on to the next question. After 2 years of ileal conduit, patient presents with lethargy and weakness. Which of the following is the most common metabolic abnormality that is seen? A. Hypocalcemia. B. Metabolic alkalosis. C. Hyperkalemia. And D is metabolic acidosis with hyperkalemia. Let's look at the various GI segments that can be used to form an ileal conduit and their associated electrolyte abnormalities. Now, we have stomach, we have jejunum, and we have ileum colon. They are classified together. Now, the stomach, as we all know, secretes hydrochloric acid, H ion, and chloride ions. Therefore, when you use stomach to form an ileal conduit, there is loss of this HCl outside the body. When there is loss of H ions, it leads to metabolic alkalosis. Right? Therefore, metabolic alkalosis can only occur when stomach is used as a conduit. Right? So it leads to metabolic alkalosis. Along with it, chloride ions are lost, so there is decrease in blood chloride levels as well. So the pH increases and the chloride level decreases when stomach is used as a conduit. Therefore, jejunum and ileum and colon, whenever they are used, it leads to metabolic acidosis. So how do we differentiate the two? Jejunum leads to hyperkalemia, right? Hyperkalemia is a medical emergency, right? Therefore, jejunum is again not commonly used. The most commonly used segment to form a conduit is an ileum. Why? Because it does not lead to hyperkalemia, right? So both of these segments lead to acidosis, whereas jejunum leads to hyperkalemia, which is a medical emergency. So this is how you differentiate jejunum from ileum and colon. Now, if jejunum is leading to hyperkalemia, then ileum would cause hypokalemia, right? So the classical abnormality that is said with ileal conduit is hyperchloremic, hypokalemic, metabolic acidosis. You need to remember this line by heart. Hyperchloremic, hypokalemic, metabolic acidosis, and also it leads to hypocalcemia as well. So let's look at our question again. They are using an ileal conduit. Now, ileal conduit can never cause metabolic alkalosis, right? And how do you differentiate an ileal conduit from a jejunal conduit? It does not lead to hyperkalemia. So the answer to this question is hypocalcemia, right? Let's move on to the next question. A case scenario was given of angiomyolipoma. Sorry, we do not have the exact question. Most likely, they would have given you the image in order to diagnose what it is exactly, and they would have given you what is this lesion associated with. So, angiomyolipomas are associated with tuberous sclerosis. So, let's discuss both of them a little bit. So, angiomyolipomas have a predisposition for females. Like all benign tumors except renal cyst, they have a predisposition for females and have a peak incidence in the age group of 30 to 40 years. They are associated with two syndromes, tuberous sclerosis and lymphangioliomyomatosis, which is associated with cystic lung lesions, lymphangioliomyomas, and chylous effusion. Right? It is a type of pecoma, that is perivascular epithelioid cell tumor. Now, in the exam, you would be given an image like this. So, whenever you are asked to identify renal lesions, there are three possibilities that they may ask in the exam. Number one is a renal cyst. Number two is RCC, and number 3 is a angiomyolipoma. These are always the three possibilities that are asked in the exam. So if the lesion appears to be a solid exophytic mass, then the most likely diagnosis is a RCC, right? Renal cyst, you can identify it's a cystic lesion and it will be water filled, right? Now comes angiomyolipoma. Now, if you see these lesions, can you see the amount of black color that is present in these lesions? How do I know that this is not water and this is fat? Just compare it with the adjacent subcutaneous fat. This black is similar in shade to this black. That means this lesion also contains fat. And any kidney lesion containing fat is a angiomyolipoma. So angiomyolipomas on CT scan have interlesional fat which has a Hounsfield unit of -15 to -20 Hounsfield unit. It is so black and you can compare it with the adjacent subcutaneous fat. Even just 20 pixels of -20 Hounsfield unit are sufficient to diagnose it, or just 6 pixels of -30 Hounsfield unit are sufficient to diagnose it. Right? So that is how you diagnose an angiomyolipoma. And it is associated with a characteristic syndrome known as tuberous sclerosis, which is an autosomal dominant disorder characterized by mutation of 9q, which has TSC1 gene encoding hamartin, or 16p, which is TSC2 gene encoding tuberil. This in turn leads to the features 10 cars. T for cortical tubers, E for subependymal giant cell astrocytoma, N for subependymal nodules, C for cyst, pancreas, liver and kidney, A for Ashleaf macules and cutaneous angiofibromas, R for cardiac rhabdomyomas, renal angiomyolipoma and retinal glial hamartoma, and S for Sjagren patches and subungual fibromas. So renal angiomyolipomas, they are a component of tuberous sclerosis, right? Which among the following is not an indication for partial nephrectomy? And the options are A. 4.4 centimeter hilar mass, B. Solitary functioning kidney, C. Bilateral renal masses, and D is upper polar mass. Now, when we talk about partial nephrectomy, there are some absolute indications for partial nephrectomy. Number one, if the mass is present in a solitary kidney. Of course, you need to preserve as much renal parenchyma as is possible in order to prevent patient from landing into CKD5. Right? Second, presence of bilateral renal masses. You cannot perform bilateral nephrectomies. Therefore, again, you try to preserve as much of the renal parenchyma as is possible. And third, renal mass with pre-existing CKD. Again, the logic remains the same. Try and preserve as much of the renal parenchyma as is possible. So if we look at the question again, solitary functioning kidney is not the answer, bilateral renal mass is not the answer. So we are left with two options, upper polar mass and 4.4 centimeter hilar mass. Now they are asking which of the following is not an indication for partial nephrectomy, right? Partial nephrectomy relative indication is decreased tumor complexity. That is, if the mass is an upper polar mass, you can simply perform it, no? Whereas if it's a large 4.4 centimeter hilar mass abutting the renal hilum, it will be difficult to perform partial nephrectomy. Therefore, in such a case, you should perform a radical nephrectomy. It is not an indication for partial nephrectomy. Partial nephrectomy is usually not feasible in such a case, whereas it is feasible in an upper polar mass, right? So if you can perform it, why not do a partial nephrectomy? Since it's feasible in an upper polar mass, it is an indication for partial nephrectomy. However, it is not feasible in a 4.4 centimeter hilar mass, and therefore it is not an indication for partial nephrectomy. Coming on to the next question, a 30-year-old male presents to casualty 6 hours after road traffic accident. Now, vitals of the patient are stable. The patient presents with complaints of abdominal pain. On examination, the patient has a distended bladder with inability to pass urine and blood at the tip of external meatus. What is the diagnosis? A. Anterior urethral injury. B. Posterior urethral injury. C. Scrotal injury. Or D. Bladder injury. Now, the patient is having abdominal pain, inability to pass urine. Why would a patient with scrotal injury have abdominal pain along with inability to pass urine? Right? He would have scrotal pain, he would have some other symptoms. If you examine the patient, the bladder is distended. Had there been a bladder injury, the urine would have extravasited, and how come the bladder would have become palpable? Right? So the bladder is distended, that means there cannot be a bladder injury. Now we are left with two options: anterior urethral injury, posterior urethral injury. Remember, always in the question, whenever the examiner wants to ask you about anterior urethral injury, they will classically give you a straddle injury, right? Whereas, whenever they want to ask you about posterior urethral injury, they will classically give you a road traffic accident. So, if they have specifically mentioned the name of straddle injury, then only you will mark anterior urethral injury, because anterior urethral injury can also have such symptoms. The combination of a road traffic accident along with these classical symptoms is characteristic of a posterior urethral injury. So the answer to this question is posterior urethral injury. Although anterior urethral injury can also have these symptoms, but they have given a road traffic accident, they would classically give you straddle injury for it. Right? So if you talk about posterior urethral injury, these are the classical symptoms that the patient has: inability to urinate, blood at meatus, and a palpable full bladder. Right? Since there is injury in here, therefore there is blood at the meatus, palpable full bladder, and inability to urinate. Right? This forms a triad. Apart from it, the patient can have a high riding prostate, and the patient can have a butterfly perineal hematoma. Right? These are the signs and symptoms of a posterior urethral injury. The injury in posterior urethral injury occurs at the bulbomembranous junction. Complete disruption at bulbomembranous junction. So this is how classically an anterior urethral injury looks like. This is what is known as a straddle injury. So your legs are separated, something hits in between your legs, right? So when something hits it between your legs, it compresses your urethra between the pubic bone and the object, right? So the location of injury in anterior urethral injury is bulbar urethra. Right? Do not get confused between the terminology. Be very specific of what the question is asking you. Now, a young male with raised alpha fetoprotein and query HCG or LDH, what is the next step in management? And the options are A. High inguinal orchidectomy, B. Scrotal orchidectomy, C. Percutaneous biopsy, and D is dogleg radiotherapy. Now, a young male presenting with raised AFP in urology points to a testicular tumor, and AFP is specifically elevated in non-seminomatous germ cell tumors. Right? So, in case of suspected testicular tumors, you never perform anything through the scrotal route. So, you never perform a percutaneous biopsy, you never perform a scrotal orchidectomy. Reason is that this is your scrotum, these are your testes. These testes drain to the para-aortic, retrocaval, paracaval lymph nodes and interaortocaval lymph nodes. Whereas this scrotal skin drains to the superficial and deep inguinal lymph nodes. Now, when you perform any surgery through the transscrotal route, it leads to seeding of the tumor cells onto the skin and provides them another route of spread. Therefore, no scrotal intervention is performed in such cases. Now, the patient most likely has a non-seminomatous germ cell tumor, and in non-seminomatous germ cell tumor, radiotherapy has no role. Therefore, the answer to this question is high inguinal orchidectomy. Right? Next step in management is high inguinal orchidectomy. And whenever we read about testicular tumors, initial management turns out to be radical or high inguinal orchidectomy. Right? Now, what is the half life of alpha fetoprotein? A 5 to 7 days, B 24 to 36 hours, C 24 hours, and D 2 to 3 days. And the answer to this question is 5 to 7 days. Right? So, how do I remember the half lives? We look at the various serum tumor markers. We have alpha fetoprotein, we have beta HCG, and we have LDH. I arrange them alphabetically, A followed by B followed by L. Now, alpha fetoprotein, it has fetus. Fetus has a very long life to live. Therefore, it has the longest half-life of 5 to 7 days. Next, we have 24 to 36 hours, and last we have 24 hours. LDH does not have long half-life. LDH half-life is not long, it is 24 hours. So usually the confusion arises between 24 hours and 5 to 7 days. Remember, fetus has to live a very long life. Therefore, the half-life is 5 to 7 days. That is how I remember it. Right? So the answer to this question is 5 to 7 days. This is the half-life of beta HCG. This is the half-life of LDH. And this is the half-life of total PSA. 2 to 3 days. Right? This was a similar question was asked in your previous exam. Coming on to the next question, a female who underwent a laparoscopic hysterectomy post-operatively developed urine leak from the vagina. Leak was aggravated on standing and occasional normal voiding was present. What is the diagnosis? A. Vesicovaginal fistula. B. Uretrovaginal fistula. C. Vesicouterine fistula. And D. Urethrovaginal fistula. Now, when you look at the question itself, you can rule out two options. The patient has undergone a laparoscopic hysterectomy. The uterus is not there. How can the patient form a vesicouterine fistula? Right? Additionally, in hysterectomy, they never go down till the urethra, so the chances of urethrovaginal fistula are not there. Now we have to choose between these two options, vesicovaginal fistula versus a uretrovaginal fistula. The patient has developed urine leak from the vagina. Leak was aggravated on standing. So what is happening is that there was some leak. The urine got collected into the vagina. Now, since the vagina has no sphincter, the moment the patient stands, there is aggravation of leak on standing. However, they have given second important feature, there is occasional normal voiding. This is the feature that differentiates a vesicovaginal fistula from a uretrovaginal fistula. How? In uretrovaginal fistula, one of the ureters is injured. Therefore, you have urine leak from the vagina. However, bladder filling is maintained by the contralateral ureter. Therefore, the patient has normal voiding. Whenever they want to give you the option of normal voiding, they want you to answer uretrovaginal fistula. Right? Let's look at other pointers also. In laparoscopic hysterectomy, there are more chances of injuring the ureter as compared to bladder. Although gynae people can do anything, but you can injure both the structures during laparoscopic hysterectomy. So the presence of normal voiding hints towards a uretrovaginal fistula rather than a vesicovaginal fistula. Right? So in uretrovaginal fistula, the most common symptom is constant urine leak 1 to 4 weeks after the surgery. It may be preceded by several days of flank pain, abdominal pain, nausea, and low grade fever due to the formation of a urinoma or obstruction of the kidney. Normal voiding habits. This is the feature that differentiates it from a vesicovaginal fistula. Right? Now, identify the sperm retrieval technique. A. PISA, B. TISA, C. TESI, and D. MISA. Now, this is the technique that was shown in the exam. Now, you need to know their full forms in order to answer this question. This is percutaneous epididymal sperm aspiration. TISA stands for testicular sperm aspiration. TESI stands for testicular sperm extraction. And MISA stands for microsurgical epididymal sperm aspiration. Now, in this technique, sperm is being taken out from the epididymis. Therefore, TISA and TESI is not the answer. And additionally, in this technique, are you able to see a microscope? So, in MISA, you use a microscope to perform such a surgery. Therefore, MISA is also not the answer. The answer is percutaneous epididymal sperm aspiration. So PISA stands for percutaneous epididymal sperm aspiration, and the advantage is that unlike MISA, it does not require any microsurgical skill, can be performed under local anesthesia, and epididymal sperm has better motility as compared to testicular sperm. Right? What is the Niagara trial about? We do not have the other options. We just have the answer to this question. Durvalumab in perioperative settings. Very, very important trial, a game-changing trial in bladder cancer. Let's discuss about it. Niagara trial is a randomized open-label phase 3 trial which was conducted in muscle-invasive bladder cancer patients who were eligible to receive cisplatin. Now they were given neoadjuvant durvalumab along with gemcitabine cisplatin followed by radical cystectomy followed by adjuvant durvalumab. And this was compared with standard therapy, that is just gemcitabine cisplatin followed by radical cystectomy. So they had used perioperative durvalumab. And it was seen that the use of this perioperative durvalumab was associated with increased event-free survival and overall survival with a hazard ratio of 0.68. Right? Adverse events occurred in about 40.6% of the patients in the durvalumab arm and in 40.9% of the patients in the comparison arm. So there was no increase in adverse events. However, the overall survival and the event-free survival improved. Therefore, this has led to the approval of durvalumab in perioperative setting and is now incorporated into guidelines. So, very important change with respect to neoadjuvant chemotherapy in muscle invasive bladder cancer is that first look at whether the patients are eligible for cisplatin. Right? How? By the Galsky criteria. If the patient are eligible for cisplatin, then you now give neoadjuvant chemoimmunotherapy to the patient. Right? So you give gemcitabine, cisplatin to the patient along with durvalumab followed by radical cystectomy followed by adjuvant durvalumab. Right? This is the latest advancement for these patients. If the patient cannot receive immunotherapy, then you again give neoadjuvant treatment with gemcitabine cisplatin followed by radical cystectomy. So you can use perioperative durvalumab in the perioperative setting. This has now been incorporated into guidelines. However, if the patient is not eligible for cisplatin, then in such a case, carboplatin is not given. This There is another very important trial, EV303 Keynote 905. This is the trial that will be asked in your future exam. This has led to the approval of enfortumab vedotin along with pembrolizumab for such patients who are not eligible for cisplatin followed by radical cystectomy. So if the patient is eligible for cisplatin, you give him neoadjuvant chemoimmunotherapy incorporating durvalumab. However, if the patient is not eligible for cisplatin, then you give him enfortumab vedotin along with pembrolizumab. Right? This is the latest change in neoadjuvant chemoimmunotherapy. Both trials, very important trial, Niagara trial and EV303 Keynote 905 trial. For adjuvant chemotherapy, this has also changed. If the final histopathology turns out to be PT3, PT4 or PN positive and no new adjuvant therapy has been given, then again first you see whether the patient is eligible for cisplatin or not. If the patient is eligible for cisplatin, then you give him gemcitabine cisplatin. However, if the patient is not eligible for cisplatin, then you give the patient adjuvant nivolumab. Right? So this is with respect to adjuvant chemotherapy in muscle invasive bladder cancer. Right? Now the next question is, which neoadjuvant drug has proven efficacy? And the options are nivolumab, B. pembrolizumab, C. durvalumab, and D. atezolizumab. Now this is a very non-specific question. They have not given the exact cancer for which they are asking this question. However, we still can rule out two options. Nivolumab is not used in neoadjuvant setting in any cancer. Similarly, atezolizumab is also not used in neoadjuvant setting in any urological cancer. So now we are left with two options, durvalumab and pembrolizumab. Right? Durvalumab is used in as perioperative setting in cisplatin eligible muscle invasive bladder cancer. So yes, it is used as in the neoadjuvant setting. Pembrolizumab is used in combination with enfortumab vedotin for cisplatin ineligible muscle invasive bladder cancer. Right? So if they are asking specifically neoadjuvant use, both these drugs are used, but of course this is the standard of care and this is used in cisplatin ineligible patient. Therefore, I would prefer to choose the answer as durvalumab rather than pembrolizumab. Right? Because this is the standard of care that is currently used. Coming on to the next question, residual tumor post chemotherapy in seminoma. Which of the following is an indication for PET-CT? And the options are size more than 1 centimeter, size more than 2 centimeter, more than 3 centimeter, or more than 4 centimeter. And the answer to this question is more than 3 centimeter. Now, if there is a residual mass in seminoma after chemotherapy, you first see on CT scan what is the size of the residual mass. If the size is less than 3 centimeter, then in such a case, you need not perform any other investigation. Right? No further treatment is required. However, if the size is more than 3 centimeter, then you perform a PET-CT for such patients. If the tumor turns out to be negative on a PET-CT scan, again no further treatment is required. However, if the tumor is more than 3 centimeter and is found to be positive on PET-CT, then you perform a RP-LND in such patients. So the indication of RP-LND in a seminoma is a post-chemotherapy residual mass more than 3 centimeter which is PET positive. The other options are salvage chemotherapy, and third is high dose chemotherapy. Right? Therefore, the cutoff that is used to perform a PET CT for such patients is more than 3 centimeter. In which of the following Optilium is used as a treatment? The options are A. BPH, B. CPPS, C. Urethral stricture, and D. All of the above. Now, first let's look at what Optilium is. Optilium is basically a drug-eluting balloon. It's coated with paclitaxel, right? So it works by two mechanisms. Number one is balloon dilatation, wherein it mechanically dilates the affected segment. And second, it delivers the drug paclitaxel, which is used to suppress the smooth muscle proliferation and minimize scar tissue formation. Right? Optilium has currently been tried in two therapies. Number one is urethral stricture, and number two is benign prostatic enlargement. Now, it has been incorporated into guidelines for the management of urethral stricture. Why? In patients who have already undergone multiple endoscopic treatment like repeated OIUs or urethral dilatation, if the patient is can undergo a urethroplasty, then this is the management of choice. However, if the patient is not a candidate for urethroplasty, then you can provide Optilium treatment for such patients. So it is indicated for recurrent anterior urethral, specifically short segment bulbourethral strictures less than 3 centimeter. Recurrent short segment bulbourethral stricture less than 3 centimeter. And this has been incorporated into the EAU guidelines. However, for BPH, it is still under investigation. Now, let's look at the question again. In which of the following it is used as a treatment? I could not find any reference for this CPPS, right? Since I could not find any reference for this, therefore the answer cannot be all of the above. Since it's not an answer, therefore this can also not be the answer, right? It has been tried in two disorders only. It is incorporated into the guidelines for this disorder, but it's still under investigation for BPH. Therefore, the answer to our question is urethral stricture, right? They have specifically asked in which of the following Optilium is used as a treatment, and the answer is urethral stricture. Coming on to the next question, image was given and identify the plot. Option we have only two options available: A, swimmer's plot, and B, waterfall plot. Now again, with respect to statistics, this is one of the favorite questions for people in AIMS. This is a waterfall plot, right? Let's look at what a waterfall plot is. Now, waterfall plots in medical field are used in oncology. How? They are used to assess the individual patient's response to a particular drug based on the tumor burden. Right? On x-axis, x-axis represents the baseline, whereas y-axis represents the maximum growth or reduction in the tumor by radiological assessment. So, upward direction represents tumor growth, whereas downward direction represents regression of the tumor. And this data is not arranged in a random fashion. It is arranged from the worst response to the best response. So this is the worst response and this is the best response. So when the data from these individual patients is arranged from the worst to the best response, it looks like a waterfall, right? That is why we have the name waterfall plot for this patient. And from this plot, you can see that this drug is quite effective for majority of the patients, right? That is the significance of this waterfall plot, right? Next question. Methenamine is given with vitamin C as a prophylaxis for recurrent UTI. What is the mechanism of action? Options are A. It is converted to formaldehyde in acidic urine. B. It induces immune response in bladder against pathogen. C. It inhibits urease enzyme. And the answer to this question is A. Converted to formaldehyde in acidic urine. Now, with the growing antibiotic resistance, non-antibiotic management of recurrent UTI is becoming a hot topic both for clinical practice as well as for your exams. Right? A variety of non-antibiotic things are being prescribed in order to prevent recurrent UTI. And methenamine is one of the latest addition to this. Now, methenamine is basically a urinary antiseptic. So 70 to 90% of this is excreted renally. And in urine, it is converted to ammonia and formaldehyde in acidic environment. Right? This formaldehyde can be either bacteriostatic or it can be bactericidal depending on its concentration. And this happens only in an acidic environment. Therefore, it is given with vitamin C. Right? Two formulations are currently available for methamine hippurate and mandylate. Right? Let's move on to the next question. 65-year-old male with lower urinary tract symptoms without dysuria or hematuria has a serum PSA of 10.4. Which of the following is incorrect? Number A. Serum PSA should not be done without ruling out UTI. B. Biopsy needs to be done if nodules are present on DRE. C. Will likely require radical prostatectomy. And D. Multiparametric MRI needs to be done. Now, a patient has urinary tract symptoms, no dysuria, no hematuria, has a PSA of 10.4. So, an isolated elevation of PSA is not an indication for biopsy. The first step with elevated PSA is always repeat the PSA in order to rule out false positive elevations. Why? Because it can get elevated due to a number of conditions including urinary tract infection, cancer, etc. etc. Therefore, the first statement, serum PSA should not be done without ruling a UTI, is correct. Right? You should repeat the serum PSA and at the same time also rule out UTI. Second, biopsy needs to be done if nodules are present on DRE. Presence of nodules on digital rectal examination confers a 5 to 30% risk of harboring an underlying cancer and is definitely an indication for biopsy. Right? Therefore, this statement is also correct. Now we are given two statements will likely require radical prostatectomy. Till now, the diagnosis is not there. However, PSA of 10.4 usually falls into a if it turns out to be cancer. If serum PSA of 10.4 turns out to be prostate cancer, most likely it will fall into the intermediate risk category. Intermediate risk category prostate cancers are usually localized to the prostate and can be cured with radical prostatectomy. So they have given a 65-year-old male. They have not given any comorbidities. So it is expected that he would be having a good life expectancy. If it turns out that he has prostate cancer, then most likely he can be cured with radical prostatectomy. So they have given will likely. They are not sure till now since the diagnosis is not established. However, if it turns out to be prostate cancer, it requires radical prostatectomy. Now let's look at the last option. Multiparametric MRI needs to be done. Needs to be done implies that it is an absolute indication to perform multiparametric MRI. No, it is not like that. With a PSA of 10.4 and again if it turns out to be elevated, you can directly proceed to transrectal ultrasound guided biopsy of the prostate. It is not necessary that it needs to be done. It is not an absolute indication. Therefore, this statement also seems to be correct, although we still not have a diagnosis. But this is a wrong statement. It needs to be done in such a case. It is not a necessary requirement. Yes, if you perform it, it can help us in guiding whether we need to perform an MRI trust biopsy or a trust biopsy. But it is not absolutely needed. Right? So the answer to this question is D. Let's move on to the next question. In which of the following patients skin graft is contraindicated? And the options are young male with lichen sclerosis, B. Post orthoplasty child with hypospadias, and C. Female urethral stricture. So the answer to this question is lichen sclerosis. Lichen sclerosis is a skin disorder, and therefore skin graft is contraindicated in such a condition. Otherwise, such a phenomena will happen in the skin graft itself, and again it will lead to recurrent stricture formation. So skin grafts are contraindicated in patients with lichen sclerosis. What about the other options? In a post-orthoplasty child with hypospadias, yes, you can utilize a skin graft, and the surgery is Bracca's repair. Right? So in Bracca's repair, you can utilize a skin graft. Also in female urethral stricture, use of skin graft has been described. Right? So these two are not the answers. Lichen sclerosis is the answer. Coming on to the next question. Patient was taken up for PCNL and after puncture, pus was aspirated. What is the next best step? A. Dilate the tract and insert a nephrostomy tube. B. DJ stenting. C. Continue the procedure. And D. Abandon the procedure. Now you have aspirated frank pus when you have punctured the kidney. In such a case, if you continue the procedure, the patient is then going to variably land up into sepsis and will land up in ICU on a ventilator. So you never continue the procedure in such a case, otherwise it will lead to sepsis. Right? So the patient basically has pyonephrosis. Right? So in such a case, you first drain the collecting system with a PCN. Give the patient adequate IV antibiotic therapy for the pus to get resolved. So you have drained the collecting system with the help of PCN, and additionally you give them adequate antibiotic treatment. Once the pus gets resolved, the patient has sterile nephrostomy cultures. Then you proceed with PCNL at a later elective date. So in such a case, the answer is you dilate the tract and insert a nephrostomy tube because it will provide you a wide bore drainage at this point of time in order to drain out the pus. Right? And when it turns out to be sterile, you can perform the PCNL at a later setting. Let's move on to the next question. Extracorporeal shockwave therapy is used in A. Peyronie's disease, B. Erectile dysfunction, C. CPPS, and D. All of the above. And the answer to this question is all of the above. Let's look at them. In Peyronie's disease, yes, extracorporeal shockwave therapy is used as an external force because it provides direct damage to the penile plaque, increases the vascularity, resulting in lysis of the plaque. Right? However, it provides pain relief only without any decrease in curvature. So yes, in Peyronie's disease, extracorporeal shockwave therapy has been described. And this is the machine that is used for it. Right? This is not like the machine of ESWL used in lithotripsy. This is a totally different machine. Now, in erectile dysfunction, although these therapies are investigational, but they have been described as restorative therapies leading to regeneration of nerves in erectile dysfunction. And again, low intensity extracorporeal shockwave therapy is one of the restorative therapy in erectile dysfunction. When you search the literature for CPPS also, they have described use of extracorporeal shockwave therapy, and therefore the answer to that question was all of the above. Now let's move on to the next question. A patient with detrusor sphincter dyssynergia with overactive bladder, with normal bladder compliance, smooth sphincter function is normal. What is the level of injury? And the options are A. Suprasacral, B. Spinal, C. Pontine, and D. Infrasacral. Now let's look at the various lesions. So the various lesions of the central nervous system can be divided into suprapontine lesion, infrapontine suprasacral lesion, also known as spinal lesions, and sacral or infrasacral lesion. Why? Because these lesions lead to specific manifestations. When the patient has a sacral lesion, the patient has an underactive bladder, right? So a sacral lesion leads to hypocontractile or an acontractile detrusor. When the patient has a suprapontine lesion, it leads to overactive bladder. So detrusor overactivity is associated with the suprapontine lesion. Whereas when the patient has a spinal lesion, that is an infrapontine and a suprasacral lesion, the patient has overactive bladder along with detrusor sphincter dyssynergia. So a patient with spinal lesion manifests with detrusor overactivity along with detrusor sphincter dyssynergia. So if you look back at the question, the patient had detrusor sphincter dyssynergia along with overactive bladder. So the answer to our question is spinal lesion. Right? Let's move on to the next question. A patient with painful erection and ABG was given. This is the most likely ABG. What is the likely diagnosis? Now we have only two options that are available. In this ABG, the pH is very, very low. Right? The PO2 is very, very low and the PCO2 is very, very high. This implies that it's a severely deoxygenated blood which is present in low flow ischemic priapism. Right? So if you look at the various ABGs, if you draw an arterial sample, the blood is bright red in color with high or the blood usually has high oxygen saturation with low content of CO2 and therefore has a pH of about 7.4. Whereas if you look at a venous blood sample, it is dark red in color. Why? Because it is relatively desaturated and has high CO2 content leading to drop in pH of 7.35. Whereas if you draw it from a patient with ischemic priapism, the blood is severely deoxygenated with a high PCO2 content and therefore a very low pH of blood and has a characteristic crankcase oil appearance. Right? Now, let's move on to the next question. Hellstorm surgery, vascular H, is used in A. UPGO, B. VUR, C. Posterior urethral valve. And the answer to this question is UPGO. This question has been repeated in the exam multiple times. Right? It's such a frequently asked question. Now, what is basically Hellstorm vascular H? So previously it was thought that these lower pole crossing vessels are responsible for extrinsic obstruction of UPJ segment. Therefore, if you dissect these vessels and hitch it to the renal pelvis, it will remove the underlying cause of obstruction and is going to cure the uretropelvic junction obstruction. Right? However, later studies found that uretropelvic junction obstruction is due to an intrinsic abnormality of the UPJ segment, leading to an aperistaltic segment. It is not due to an extrinsic obstruction. Right? Therefore, this surgery is not commonly used nowadays. And if you look at Campbell, it has specifically mentioned patients who have mild to moderate hydronephrosis with preserved renal function, wherein this is the extrinsic cause of obstruction. It is the only indication wherein Hillstrom vascular H is used. However, how are you going to identify whether it's due to an extrinsic cause or intrinsic cause? Right? So this surgery, although it is quite simple to perform, is not used nowadays. However, it is important from your exam point of view. Right? Next question. Briganti score is used in, and the options are A. Extracapsular extension in CA prostate, B. Lymphovascular invasion in CA prostate, C. Lymph node involvement in CA prostate. And the answer to this question is lymph node involvement in CA prostate. Why? So first of all, why do we use these scores itself? If we look at the various imaging techniques like MRI and PET-CT, they both have very low sensitivities for the detection of pelvic lymph nodes, with sensitivity of less than 40% for MRI and less than 60% for PSMA PET-CT. That means almost half of the lymph nodes are missed by these imaging modalities. Therefore, you use nomograms to assess the risk of lymph node involvement in patients with prostate cancer. And the various nomograms that are used are number one, Briganti nomogram, second is MSKCC formula, and the third is a Roche formula. Right? These are the three nomograms used to assess the risk of lymph node involvement. And if the risk of lymph node involvement turns out to be more than 2 to 5%, then you perform a bilateral extended pelvic lymph node dissection. 2% according to NCCN guidelines, 5% according to EAU guidelines. Right? Now, which of the following is true statement for normal semen analysis according to WHO 2021? Sperm concentration more than or equal to 15 million per ml. Overall sperm motility more than or equal to 40%. Sperm volume more than or equal to 1.4 ml. And progressive motility more than or equal to 32%. And the answer to this question is sperm volume more than or equal to 1.4 ml. Now, these people are very smart. They have asked you the WHO 2021 criteria. That is, they want to specifically ask you the latest WHO edition, that is the 6th edition, for evaluation and processing of humans' semen. Right? So, previously we used to follow the 5th edition WHO 2010 for a very long period of time, but now we have the WHO 2021 edition, and it has led to change in various cutoffs. So the semen volume cutoff has changed from 1.5 to 1.4 ml. The semen concentration cutoff has increased from 15 million to 16 million. Total sperm count has remained the same. Overall motility has been increased from 40 to 42%, whereas progressive motility has been decreased from 32 to 30%. Vitality has been decreased by 4%, and normal forms remain the same. Right? So these are the changes in the latest WHO edition manual. Coming on to the next question. XTIK-TR is a type of A. Gamma rays, B. Proton beam therapy, C. Intensely modulated external beam radiotherapy, and D. Self therapy. And the answer to this question is self therapy. XTIK-TR is not a form of radiation. It is a form of self therapy. So let's look at what basically XTIK-TR is. It is one of the forms of liquid urethroplasty. Now, liquid urethroplasty is one of the latest advancements in the management of urethral stricture disease. So, why it is known as a liquid urethroplasty? Because you are using buccal mucosal graft in the form of a liquid, right? So, instead of a solid graft, you are using a liquid graft. How? You harvest the buccal mucosal graft 1 to 1.5 centimeter. Then you culture autologous buccal epithelial cells. This takes usually a period of about 3 weeks. And then You perform an endoscopic implantation into the urethral structure. How? You perform an optical internal urethrotomy, and within that defect, you inject this liquid buccal mucosal graft. Right? This therapy is also known as AALBEC, autologous adult live cultured buccal epithelial cells. Quite a complex name. And the brand name is even more complex, XTIKTR, that is available in India. Right? So this is basically a form of liquid urethroplasty and it's a form of self-therapy. Coming on to the next question, image was given and you were asked to identify the condition. So this was the image that was given. Herein you can see an elongated bladder. So normally the bladder looks like this. However, it has become trabeculated and elongated, and such a bladder is characteristic for neurogenic bladders. In addition to that, this reflects into the right system, so the patient has right viewer also. So this is an image of neurogenic bladder with right viewer. Neurogenic bladders have been repeatedly asked in your exam, and this is the characteristic image of a neurogenic bladder. It is also known as Christmas tree or pine cone appearance of the bladder. Right? Do not confuse this image with the image of a thimble bladder. Right? Thimble bladder occurs in tuberculosis. So neurogenic bladders have been asked repeatedly in your exam and you should know their characteristic images. Right? Which of the following statements is correct? Now we have only one option and that is MAG3 is cleared by tubular secretions. Right? So let's look at the various radio traces. We have three radio traces that are commonly used. Number one is technetium 99M DTPA, diethylene triamine pentaacetic acid. Now it is excreted by glomerular filtration and therefore can be used for GFR estimation and for assessing obstruction in the pelvic calyceal system. However, since it is excreted by glomerular filtration, it is of less use in CKD patients. Since in CKD patients, the GFR is already less, therefore it is not commonly utilized in patients with CKD. Right? Technetium 99M DMSA, dimercaptosuccinic acid. Now this localizes to proximal convoluted tubules of the renal cortex. Right? Therefore, it is used to identify ectopic or aberrantly located kidneys. Third is technetium 99M mag3, which is excreted by tubular secretion. Since it is excreted by tubular secretion, it cannot be used for GFR estimation, but it can be used to assess obstruction in the pelvic calyceal system. And it can also be used in CKD patients. Right? So the answer to this question is MAG3 is secreted by tubular secretion. Next question. Which of the following is Chinese robotic surgery system? And the options are A. Taomei system, B. Revo-I, C. SSI, and D. Hinotri. And the answer to this question is Taomei system. Now, a variety of robotic systems have been developed by different nations. You need to remember this list by heart, right? Just the names and the country of origin are sufficient. Da Vinci system is the most commonly used system. Previously, we used to use the version of Da Vinci Xi. But now we have the latest advancement of DV5, right? It is developed by the company Intuitive Surgical in USA. SSI system is a made in India system. SS stands for Sudhir Shrivastava. the person who started this company. Hugora's system is established by Medtronic in Ireland, and Vercius system has been developed in UK. These four robots are available in India. Revo I is a system which has been developed by South Korea. It is basically just like a replica of Da Vinci system. Hinotri is made by Japan, and Taomi system is developed by China. Evitera has been developed by Germany, and US has developed another system known as Senance system. Go to Google, have a look at all how all these systems look like, right? So these are some of the pictorial images. This is an image of Da Vinci XI system, right? And this is its latest DV5 version. This is the SSI Mintra system, although a better image will be available on the respective site. This is the Hugo Ras system. This is the Revo I system, which is basically looks like a replica of Da Vinci Xi only. And last you have the Hinotri system. Coming on to the next question. High level disinfectant false statement about glutaraldehyde is. And we have only one option available. Contact time duration is 10 minutes. This was the answer. So let's look at high level disinfectants and glutaraldehyde in specific. So we have a Spalding classification that is used in order to classify the various instruments that are used. And these are classified into three levels. One is critical, two is semi-critical, and third is non-critical. Now, critical items are those that enter the sterile system or the vascular system. Example include your scalpels. And all such instruments should be sterilized. Semi-critical items touch the mucous membrane or the broken skin. Example includes your endoscope. And they should undergo high-level disinfection. Non-critical items touch your intact skin only. Example, your stethoscope, your BP cuffs. And they should undergo low to intermediate disinfection. Glutaraldehyde is a level of high-level disinfectant. Therefore, it is used for endoscope and lab procas. Right? How does it act? It acts by alkylation of the sulfhydryl enzymes and amino acid, and it is used in a concentration of 2.45% weight by volume. Its use life is about 14 days. When you place endoscopes in glutaraldehyde solution, that is Cydex solution, for about 20 to 30 minutes, they get disinfected. However, if you place them for 12 hours, they get sterilized. But you should not utilize glutaraldehyde for sterilization because it can cause damage to the cement and therefore fogging of the scopes. And before you place them into glutaraldehyde, you should decontaminate, clean and dry the instruments before soaking. If the instruments are wet, then it can lead to dilution of the glutaraldehyde solution and thereby does not lead to disinfection. Therefore, the contact time of glutaraldehyde for disinfection is 20 to 30 minutes, not 10 minutes. Oral GnRH antagonist approved. And the options are A. Relugolix, B. Degarelix, C. Gozrelin, D. Darolutamide. And the answer to this question is Relugolix. This question has been repeated at least 5-6 times in your exam. This is the only oral GnRH antagonist that is available till now. Degarelix is also a GnRH antagonist, but it is injected subcutaneously. Gozerelin is a GnRH agonist, and darolutamide is an androgen receptor targeting agent. Right? So, Relugolix is used in a dose of 360 mg per day for first month, followed by 120 mg per day. It was approved after the Hero 3 trial, which compared it to leuprolide and found that use of this relugolix was associated with decreased cardiovascular side effects to almost half and more rapid and durable suppression as compared to leuprolide. Right? Now, which of the following is protective against renal injury in ESWL? Start with option A, start with lower energy and then gradually escalate. Option B, increased number of shocks. Option C, shorter period of shock administration. And option D, higher voltage of shocks. And the answer to this question is option A, start with lower energy and then gradually escalate. So let's look at what are the various aggravating factors for ESWL tissue injury. Number one is number of shocks. Of course, more the number of shocks, more the chances of renal injury. Second, period of shockwave administration, shorter period increases damage. How? Let's compare the frequency of 60 shocks per minute versus 90 shocks per minute. So within the same amount of time, you have given the kidney energy of 60 shocks, whereas in 1 minute you have given the energy of 90 shocks. So a larger amount of energy is delivered within the shorter period of time. Therefore, the chances of renal injury are higher with higher frequency, that is a shorter period between the shocks. Third, accelerating voltage. Higher voltage implies higher damage. Of course, when the voltage is high, it can lead to increased renal damage as well. Next, type of shockwave generator, first versus second or third generation devices. Now the Dornier HM3 used to be the gold standard because it had a large focal zone. Nowadays, lithotripters have high peak energies with short focal zone. So let's suppose this is your stone. When you have a large focal zone and the entire stone falls within the focal zone, it leads to better lithotripsy. When you have a narrow focal zone, not only it leads to decreased lithotripsy, but also when due to kidney respiration, this focal zone moves out of the stone, it can provide high peak energies to the kidney, which can lead to increased chances of damage to the kidney. So when the focal zone moves out of the focus onto the normal renal parenchyma due to the short focal zone with high peak energy, it can lead to increased damage. Next, we have the kidney size. Increased age is associated with increased chances of injury. And pre-existing renal impairment is also a risk factor for aggravating the kidney injury post ESWL. The relieving factors include treatment at a slow rate of shockwave delivery, which we have already discussed, and pre-treatment with 100 to 500 shocks at low energy level to reduce the lesion size. This is known as ramping up protocol and is thought to protect the kidney due to vasoconstriction. Right? Next question. Elderly male with localized high grade CA prostate. Which of the following is true? Radical prostatectomy is superior to radiation therapy. Both radical prostatectomy and radiation therapy with ADT are equivalent. C. Radiation therapy with ADT is superior to surgery. Now, radical prostatectomy and radiation therapy have equal efficacy. So the answer to this question is not A, it is not C, it is B. Both of them are equivalent. How these two therapies are different? They are different in terms of their side effects. Radical prostatectomy is associated with improvement in obstructive urinary tract symptoms. It may lead to improvement in irritative urinary tract symptoms. And it is associated with urinary incontinence. Radiation therapy leads to initial worsening of obstructive urinary tract symptoms. However, over a period of 12 months, these symptoms return to baseline and after that it is followed by improvement in urinary tract symptoms. This worsening is especially more after brachytherapy due to edema of the prostate gland. Radiotherapy is associated with worsening of urinary tract symptoms. However, it is usually not associated with sphincteric incontinence. Radiation therapy can lead to radiation proctitis, which is not associated with radical prostatectomy. And both radiation therapy as well as radical prostatectomy are associated with erectile dysfunction in radical prostatectomy as well as in radiation therapy, especially with external beam radiotherapy as compared to brachytherapy. Right? So both of them have equal efficacy but differing side effects. Now, which of the following is incorrect? MDRD formula is accurate in the late stage. Cockcroft Gault formula underestimates GFR in CKD patients. And the answer to this question is B. This is incorrect. How? I will explain it to you. Just look at the formulas. Now, these three formulas are used for estimation of glomerular filtration rate. Right? Some of the factors are common to these formulas like age, gender, and serum creatinine. These three factors are present in all the formulas. Right? However, Cockcroft-Gault formula has weight as additional factor. MDRD formula has race and CKD EPI also has race as factor. So Cockcroft-Gault formula has weight apart from these three factors and MDRD uses race. MDRD and CKD EPI. Now, in CKD patients, there is volume overload due to inadequate excretion of water. So the weight of the patient increases. When the patient weight increases, this leads to overestimation of GFR. Therefore, this formula is no longer used for the estimation of GFR, it is just used for drug dosing purposes. Since weight is incorporated as a formula and it can lead to overestimation of GFR. MDRD and CKD EPI are the formula which are used to estimate GFR, especially in CKD patients, because they are quite accurate. So if you look at the question again, Cockcroft-Gault formula does not underestimate, it overestimates GFR in CKD patients. Whereas MDRD formula is accurate even in late stage of CKD. In renal transplantation, which factor does not increase the graft survival? And the options are HLA compatibility, B rhesus group, C ABO incompatibility. Now, even if you know very little bit about the renal transplant, the first thing whenever a donor and a recipient comes, so whenever a donor and a recipient pair comes to your OPD, the first thing that you ask them apart from their relation is their blood group, because this is a very very important factor that can affect your graft survival and therefore is not the answer to the question. Second important thing, if you would have looked at the testing of patients, is the HLA compatibility that is routinely performed for both the donor as well as the recipient in order to see their compatibility. And again, it affects their graft survival. RH factor does not affect the graft survival. Right? In which of the following scenarios there is highest risk of injury to the upper tract? Sorry, we do not have the other options available. The answer to this question is low bladder compliance less than 20 ml per centimeter of water. How? I can explain you the mechanism because of this. Now let's say this is your bladder. Bladder is like a balloon. It expands with filling of urine and thereby prevents rise in intravesical pressure. Now, since there is no rise in intravesical pressure, this pressure is not transmitted to the kidneys. However, if the bladder becomes non-compliant, that is, it becomes fibrosed, it cannot expand that easily and it leads to rise in intravesical pressures. When the pressures rise beyond a certain point, these anti-reflux mechanisms get overwhelmed and these pressures can get transmitted to your kidneys. And this in turn can lead to damage to the kidneys. So low bladder compliance leads to rise in intravesical pressure, which can overwhelm your anti-reflux mechanism and can lead to transmission of pressure to the kidneys and kidney damage. Right? Next question. Best practice to mark the preoperative site. And the options are operating surgeon himself should mark the site of operation preoperatively. Site marking should be done over bandages. And the answer to this question is A. So I'll tell you a salient features of site marking. Number one, who should perform the site marking? Either the operating surgeon himself or the person delegated to obtain the consent. When you should perform the site marking? At the time of confirmation of consent before shifting the patient to OT. And patient should be involved, the patient should be awake and aware. Where you should perform the marking? Marking is an arrow pointing to the site of operative procedure as close as possible to the incision site. And this mark is made with an indelible permanent black marker pen. It should be sufficient to remain visible after skin preparation. Otherwise, it will get dissolved out with the skin preparation. All marking should be made in conjunction with checks made from the patient diagnostic imaging tests. Right? And the final step, the surgical team should do a final check called a timeout right before the start of the surgery in order to confirm the mark that matches your chart. Right? So these are some of the important points with respect to preoperative site marking. Absence of vas deferens is associated with, and the answer is renal dysgenesis. So if we talk about congenital absence of the vas deferens, it can occur due to two causes. Number one is due to CFTR mutation. This usually leads to congenital bilateral absence of the vas deferens. Second way in which a vas deferens may be absent is due to absence of the mesonephric duct. This usually leads to unilateral absence of the vas deferens. Now, this mesonephric duct not only leads to formation of the vas deferens, it also sends signals to the congenital metanephros. Since it communicates with the metanephros, it can lead to abnormal development of the kidney and it is associated with renal agenesis. Right? So, congenital absence of the vas deferens, they have not mentioned whether it's unilateral or bilateral, can be due to absence of mesonephric duct and is associated with renal agenesis. Least chances of nerve injury, and the options are A. Intrafacial dissection, B. Interfacial dissection, and C. Extrafacial dissection. And the answer to this question is intrafacial dissection. They have asked least chance of nerve injury. How? Let's look at it. This is your prostate. Prostate is surrounded by the prostatic fascia all over it, right? Anteriorly and laterally, we have the levator fascia, and posteriorly, we have the Denon Villiers fascia. So the neurovascular bundles are located posterolaterally between the two layers of fascia, that is your prostatic fascia and your Denonvillier levator fascia. So when you perform an intrafacial dissection, that is within the prostatic fascia, there are no chances that these nerves will get damaged. However, it can lead to positive surgical margins. When you perform an interfacial dissection, what you do is that you transect this levator fascia anterolaterally. And you slowly release this fascia so that this neurovascular bundle gets separated from the prostatic pedicles. And you can ligate these prostatic pedicles separately. This is what is known as high anterior release of neurovascular bundle. Yes, this can result in preservation of neurovascular bundles and preservation of nerves, and it usually results in complete excision of localized prostate cancer. Right? So the nerves are also preserved in interfacial dissection, but the least chances of nerve injury are in intrafacial dissection. Extrafacial dissection is outside the non-villar fascia and invariably leads to transection of these nerves. So if we go back to the question again, this is associated with the least chances of nerve injury. Nerves can also be spared in this, but not to the extent of intrafacial dissection. Laser which is not used in stone, and the options are A. CO2 laser, B. thulium laser, C. holmium laser. Holmium laser with a wavelength of 2140 nanometer is used in stone surgery. Thulium laser is the latest addition to stone surgery and has a wavelength of about 2000 nanometer. CO2 laser has a wavelength of about 9400 to 10600 nanometer and is used for dermatological purposes. Superficial dermatological purposes, it is not used in stone surgery. Right? So this is the answer to our question. Thank you.